Thank you for inviting me, and this is an exciting day. Ending up with the aging brain and the degenerative brain is a real decision. I will try to keep it a little optimistic at the end. But just to put us all into the time course, children who are born now will probably live with the current medicine to the age of 120 or maybe 140. So diseases that are now diagnosed at the 60s or 70s will be diseases of midlife. And this is, as we all know, a real crisis. I will discuss mainly Alzheimer's disease, which is mainly cognitive problem, and Parkinson's disease, which is motor disturbances with other non-motor features. In terms of numbers, just to put us into the general prevalence in Israel, about 120 patients with Alzheimer's disease and 25,000 patients with Parkinson. So this is for our understanding of the magnitude of the problem. If we look at the age-specific prevalence of dementia according to age in the different world regions, one can easily see that from the age of 75 on, there is a sharp increase in the prevalence. In some areas, like the Latin Americans, you can see the prevalence reaching up to 90% at the age of 90. And if we're looking at the US, more than 80% of the patients with Alzheimer's are over the age of 75. So, as I said, 75 will be probably something around midlife in 100 years. If we're trying to look at the time course from 2010 to 2050, the frequency or the prevalence of Alzheimer's disease in the US, you can see the sharp rise in the number of patients at the age of 85 and older. So we are facing a real epidemics, and the only way to fight it is to diagnose and prevent it. And I'll try to show you that we are on the way to diagnose it early and hopefully to treat it and decrease its frequency. But just to put us all into the general concept of neurodegeneration, this is the normal brain. The degenerative brain is smaller. And if we look at MRIs, we can see the normal brain and brain of a patient with Alzheimer's disease, significant decrease in brain mass. The black is the fluid that is around the brain and within the ventricles to reflect significant atrophy. It's not only atrophy, it's not only loss of tissue, but we can demonstrate that by giving glucose, the normal brain is uptaking glucose very nicely to reflect the cell function. The Alzheimer's disease patient has a significant decrease in uptake of glucose to reflect decline in cell function as well. And we can also demonstrate that in addition to the loss of tissue and decrease in function, there is a deposition of amyloid in this case. This is a normal person with a scan that is demonstrating the positions of amyloid, and a patient with Alzheimer's disease, significant increase in this deposition throughout the entire brain. So it's tissue, function, and a deposition of some pathological proteins. We can also demonstrate the extracellular deposition of mainly amyloid and the intracellular deposition that is mainly tau. And with this background, let's now understand how does it all starts and progresses. So in Alzheimer's disease, sometime very early on, some pathology is starting in the middle temporal lobe in the hippocampus, the area of the brain that is responsible for memory. It will take 16 years before the entire hippocampi will be full with this abnormal or pathological proteins to reflect the disease. Another 10 years, half of the brain is already affected, And this is the first time a person will complain of some memory loss, what we are calling mild cognitive impairment. It's not a disease state, because many of us are complaining about memory loss. And there are many reasons for memory disturbances. Some are reversible, and some are early markers for future Alzheimer. It will take another 5 years, in general, before we will diagnose Alzheimer's disease. So more than 30 years from time of first seeding of the disease process till we are diagnosing Alzheimer. We all must agree that this is a very, very long time to make a diagnosis of a disease. We know now that this process of progression of the pathological process within the brain is different. If we're looking at the amyloid deposition, it goes in one direction. If we're looking at the tau deposition, it goes in a different direction. But altogether, there is a progressive accumulation of abnormal proteins within the brain to cause this terrible clinical syndrome. If we put it on the time scale of years, because we had earlier this morning billions of years, and then millions, and then hundreds of thousands and thousands, and now we're talking about years, this is the normal aging. And Alzheimer's disease is not enhancing of aging. It is a pathological process that has a long preclinical phase, whereas I have shown you some abnormal pathology within the brain with no specific symptoms, some complaints but still not a disease, till we get to the state where a disease can be diagnosed. The question is, when and why, at this stage, back 30 years ago, the disease has started? Now, it is a very important question, because if we look, this is the previous graph with the healthy state, MCI, and Alzheimer, and this is the rate of loss of brain cells. And as easily can be picked up, the rate is fastest and most significant at a stage where there are no symptoms. So if we want to cure or treat or prevent or slow down the pathological process, we must identify the disease at a stage where there are no symptoms. This is where we can intervene and get the best benefit. This is a study from more than 10 years ago, when 1,265 subjects who are 72 years of age, all healthy, were followed for 9 years. 215 of them have developed Alzheimer's disease. And the researchers have looked back, and 9 years earlier than the diagnosis, they could already differentiate between those who are on the road to develop Alzheimer comparing to those who have stayed normal 9 years later. So there are some early markers, but they are not specific enough for us to detect a disease. If one looks at verbal fluency, it's even easier to dissect the two groups, those who have stayed normal and those who have developed Alzheimer, similarly with visual memory, to show us that in spite of saying these are normal people at the age of 72, healthy by all means, if you test them specifically at some cognitive functions, you can detect decrease in function that at the group level can differentiate them from those who have stayed normal. This is a very important concept, that normal or healthy is relative to what you are testing and how you compare it to others. Even more interesting, at that specific group, they look at those who have developed Alzheimer, and they divided them into those with high education and low education. Back 9 years earlier, before Alzheimer was diagnosed, one can see that those who had higher education at background have progressed slower at the first 5, 6, 7 years, and then sharp decline in their cognitive function. Those who had lower education have progressed faster, but they all reached a similar stage of a disease state. So here we can claim that this is the cognitive reserve that one has developed over the years. What you are actually doing now, you are enhancing your cognitive reserve to slow down any possible progression of a pathological process. Another study who have followed here 1,000 subjects, age 80, for 15 years, and they could demonstrate nicely here, looking at free recall, that the pathological process or the decrease in memory, if this is the time where Alzheimer was diagnosed, there is a significant enhancement of the pathological decline in memory function 7 years prior to the diagnosis. So this is not linear. We are using some cognitive reserve. At one point, this is not enough, and some abnormal function starts to occur, but this is not enough to make a diagnosis of Alzheimer, but on a group level, one can detect those decreasing of cognitive function. As in memory, one can show the similar pattern in aware generation. So 3 years before the diagnosis of Alzheimer, there is a change in the slope, enhancing the rate of progression. Again, I would claim that this might reflect some cognitive reserve. We are looking for biological markers that will help us detect those at risk, or actually those who are having the disease, but not at the stage that we can detect it with current mechanisms. And there are many that are now used. A-beta can be detected in the CSF, the tau, brain structure. All one can see here that years before any symptoms occur, there are changes that reflect the disease process. And if we can detect it at this stage, we can hopefully treat them early enough, years before the complaint of memory loss will appear. Now let's go back to the cognitive reserve, because I think this is a very important concept for early detection. As I've shown you, if you have high cognitive reserve, you can tolerate the disease state or the pathological process in a much better way. So in general, we are using the basic everyday function, which is declining slowly over the 90 years of life span. We have the theoretical functional reserve. This is something that is difficult to measure. Actually, we are unable to measure. But theoretically, there is a reserve that is decreasing over the years, and we are using it under extreme circumstances. If this reserve is big, we can tolerate severe stress, severe tiredness, a disease state, anesthesia, and other states where our brain has to recruit all its reserve. Subject who have genetic Alzheimer, we can claim, this hasn't been shown clearly enough, but this is a theoretical model, that they are starting at a lower state, they have lower cognitive reserve, and as a result, they reach the state where they cross the everyday function line and develop a disease at the age of 50 or 60. At the other end, people who had stroke, head injury, surgery with anesthesia have sharp decline in the cognitive reserve. Then they are trying to recover, but in the next 5 or 10 years, they reach the similar state now at the age of 75, where a disease can be diagnosed. In most cases, this is the curve, that somewhere in midlife, maybe 30, 40 years of age, some pathological process starts to occur. There is a decline, which is different between different people. As I've shown you, if you have a higher education, the decline is probably slower. the slope is shallower, but at one stage, at the age of 75, 65, or 85, a subject will reach this point where they cross the everyday life expectancy. This also tells us that any increase in demands, for example, stress, anxiety, depression, lack of sleep, medications, anesthesia, general metabolic problems, if you don't have a reserve, you will reach those places or those points in time where you will start having symptoms much earlier than others who have a lot of reserve. The problem that modern science is facing, that we do not know how to measure this reserve. If we will be able to quantify reserve on a personal basis, we can predict who will develop dementia after cardiac surgery, or when the dementia will occur after stroke. This is a real mission that we are facing, and we are trying to go there. Now, just to demonstrate the reserve, this is a normal person, and this is a normal person when you test them neuropsychologically. This is a patient with Alzheimer's disease. Look at that person who has much more amyloid deposition, even more than a patient with Alzheimer's disease, but he has no symptoms, to reflect that it is not the amount of amyloid that is playing the only role, but the amyloid with the other reserves that we can develop or we have from our better genes, our protective genes, that will decide when we are becoming sick or when we are tolerating a disease state and are asymptomatic. Now let's move from Alzheimer to Parkinson, where the picture is even more amazing. Because, again, this is a protein, synuclein in this case, that is deposited firstly in the brainstem and in the olfactory bulb, and slowly is progressing to affect the entire brain. This is a process that takes about 40 years. We are diagnosing Parkinson as of today based on the motor symptoms, the tremor, the slowness, the muscle stiffness. And this is the result of a degeneration of dopaminergic cells in the substantia nigra. This is where it sits, in the midbrain. So when 80% of the cells have degenerated, we start experiencing some tremor. So very long period of degenerative process with no motor symptoms. However, there are many other symptoms that can be detected and can reflect the disease process. This is the neurodegenerative process, the decline in the number of cells, on the efficacy of the cells, and the clinical motor symptoms. No motor symptoms here. There are some risk markers, like aging, for example, or genetic factors that I will discuss, but there are prodromal markers. For example, abnormal sleep while dreaming. I will discuss it in a second, but loss of sense of smell, depression, autonomic dysfunction, erectile dysfunction, blood pressure problems, mild motor signs like slowness, constipation, depression, pain, all have been shown to be early markers for Parkinson's disease. The disease will be diagnosed based on the motor symptoms here. There are already motor symptoms that are not significant enough for us to make the diagnosis. However, if we want to treat a person at the early stage, we must start looking at those early prodromal markers because they are reflecting a disease state. Even though not everybody with constipation will have Parkinson. But if you combine Rem sleep behavioral disorder, constipation, depression, and hyposmia, this is a significant marker. Now, just to demonstrate what is this Rem sleep behavioral disorder, this is in a sleep lab, a person we know from the sleep lab that he is now in the dreaming phase of sleep. And during sleep, instead of being paralyzed, he is acting the dreams, and this is one of the few reasons to fall from bed during sleep. Just think about it, that we all sleep throughout our life, and we don't fall from bed. We know when we turn right or left to prevent falls. In this case, because of the acting out of the dream, they fall from bed as a marker for REM sleep behavior disorder. So researchers have taken 89 subjects with REM sleep behavior disorders, people who had only acting out during their sleep phase, followed them for 10 years. They had those symptoms for 9 years before that, so up to 20 years. And if they followed them for 10 years, 80% of them who were completely healthy developed Parkinson. And if you go long enough, up to 30 years, 90% of the people with REM sleep behavior disorders will develop Parkinson's disease. So this is a very significant and sensitive marker for future Parkinson. If you add the REM sleep behavior with olfaction, or with color vision problem, or with mild motor dysfunction, or autonomic dysfunction, you can get a much higher score, and this is what we are trying to do. We are trying to detect those who will develop Parkinson out of those who have those non-specific symptoms. So we are ending up with a Parkinson pyramid. I will start by saying that if you take a population at risk based on their genetic background, for example, in Israel, we have 250,000 people with mutations that are associated with Parkinson. But only 25% of them will develop Parkinson until the age of 80. So it's a real mission to try to understand who will develop Parkinson. We are trying to look for biological markers, like sniffing to detect hyposmia, sleep problems to detect the REM sleep behavior disorders. We are collecting cerebrospinal fluid to detect biochemical markers. And we can scan subjects and detect their early dopaminergic deterioration or degeneration. So there are markers that can tell us Parkinson is coming, the degeneration is progressing. So what we have been doing for the past 10 years in Ichilov, we are following about 1,500 Ashkenazi patients with Parkinson's disease, and a large number of them have a known mutation causing disease. So we took those patients who are already having Parkinson, and we called in their first-degree relatives. And we are following currently, after almost 600 subjects who are completely healthy, a mean age of 55, follow them prospectively to try to understand who will develop Parkinson and when. And as you can see, we have a large number of healthy subjects with mutations, and we know who is on its way. We know that this subject with abnormal smell, abnormal gait, abnormal scan will develop Parkinson, and we already have 11 subjects who came to us as normal first-degree relatives at their early 50s and developed Parkinson in front of our eyes. And what is striking is that the turning from being a healthy subject at risk to a patient happens overnight. They call us, for the past week I have tremor, or I feel some stiffness in my leg, or something has happened to my walking, to show us that the reserve, like the cliff that I've shown you earlier, we are exhausting the reserve up until a point that we are falling the cliff, and then symptoms occur. So the mission is to detect in early stages those who are at risk for prevention or curing. And we are going there. And this is the optimistic part. Up until now, I know that I gave you some very difficult story. So just one of the recent publications, this is from Nature from a year and a half ago, using an antibody against amyloid, and this is a phase 2, still to be proven in a phase 3, but people who have gotten a placebo, the amyloid deposition, no change. People who got the antibody, the immunization, intravenously, you can see the placebo, and as the dose of the antibody increased, there is a significant decrease in the amount of amyloid deposition. So if we will have an immunization that can prevent or stop from progression Alzheimer, that would be great. So the mission is, if this is the cause of the disease, we have subject at risk, we are diagnosing the disease very late. And this is an analog to cancer. Think, for example, on breast cancer. There were times when women were diagnosed with breast cancer when there was a lump of 5 centimeters. Most of them died within a year or 5 years. Now, when you are detecting the cancer by an MRI at the size of 2 millimeters, most women survive. So what we have to do, exactly the same with neurodegeneration. Detect the disease early, because now what we are doing is we are giving symptomatic treatment. We are not changing the real course of the disease. We should slow down the rate of progression. Hopefully, we will be able to stop the progression. So if we will detect the Alzheimer or the Parkinson at the very early stage, we will have an effective treatment. Hopefully, we will stop the progression. But our real aim and mission is to detect those at risk early enough with no symptoms in their 40s or early 50s, give them a prevention treatment, and avoid the disease altogether. This is not a dream. And there are many different ways to reach this goal. For example, using, as I've shown you, vaccines, gene therapy, ASOs, RNA silencing, small molecules, stem cell therapy, all are being tested now, and none of them have been proven to be effective, but we have a very effective treatment that we can all use, and this is exercise. Exercise has been shown to decrease the risk for Alzheimer, decrease the risk for Parkinson. We are giving now a prescription for exercise, and we know that this is not just to be fit. It's because exercise is bringing trophic factors to the brain that improving its function, hopefully increasing its reserve and preventing or slowing down the disease process. So it's at least a proof of concept that by behavioral modification, we can actually prevent or slow down or delay significantly the occurring of those terrible diseases. So there are many patients and relatives who are waiting, and we have to work hard. Thank you.
Neil, first of all, thank you so much for a very informative lecture. Second, I'm very happy that you concluded your lecture with some upbeat, with some optimistic prescription. I have one question before we take 2 or 3 questions from the audience. If you have a patient that falls off his bed for 9 years, every night, wouldn't it be expected to...
I would look for his spouse or his bed partner to see what is happening there.
Yeah, but if he's single, then he will get Parkinson just by hitting his head.
That's true. Actually, head trauma is okay. One of the reasons for both Alzheimer and Parkinson.
So I hope that everybody listened carefully to the last 3 minutes, because otherwise you are going to fall off your bed tonight. And we'll take a few questions.
Thank you for a wonderful lecture, and thank you for the emphasis on prevention and exercise. In the early discussion of Alzheimer's disease, you said repeatedly that anesthesia is a risk factor for the development of Alzheimer's. has anyone calculated the impact of anesthesia for colonoscopy on the risk of Alzheimer's? And do we know whether we could reduce or eliminate anesthesia that is not necessary to reduce the risk of Alzheimer's subsequently?
So anesthesia, first of all, we all are familiar with those people who go to the operating room and come out completely confused with delirium, and others in the same age or even older who come out of general anesthesia with no problem whatsoever. It's a stress to the brain, and we can differentiate people probably with cognitive reserve. We would like to test those who are going into the operating room and predict ahead of time who is going to develop the delirium, the confusion. Anesthesia is causing stress. It probably repeated anesthesia, general anesthesia, has some deleterious effect on brain function. It is not quantified, and it's not necessarily Alzheimer, exactly the pathological process of Alzheimer, but there is an increased risk for cognitive decline with repeated general anesthesia. And the level of anesthesia and it's to quantify it, I'm not sure that I can give you a good answer. If light anesthesia for colonoscopy is the same as having 6 hours of general anesthesia for cardiac surgery.
So we can take 2 more questions, none of them about colonoscopy.
In Rem Behavior Disorder, you have the marked example of somebody falling with their beds. Quite a few people acting out. I'm talking about Rem Behavior Disorder. You mentioned falling off the bed, which is a marked symptom. We sometimes get patients who have mild symptoms, like acting out their dreams to the point that they knock their spouse or raise their hand or yell. Is that in the same category?
So in order to diagnose REM sleep behavior disorder, you can do it by questioning, but this is not fully accurate. You have to have a full polysomnography in the sleep lab to make sure that these movements and shouting and hitting are happening during the REM sleep. By the way, just to link to Nava's talk earlier, the melatonin is one of the few treatments that can affect REM sleep behavior disorders. So it probably has some connection with the melatonin level, but not fully clear how does it happen.
Although I'm not a physician, I can tell you that if you hit your spouse in sleep, this is a danger for her, a risk factor for her. Last question.
Thank you for a very interesting lecture. You mentioned that there is a cognitive reserve, and exercise is a good way of preventing, to a certain extent, the onset of Alzheimer's. What if somebody cannot do exercise? Is there any other way a person can do something to try and prevent the onset?
So actually, this is the dream pill would be to take one pill at bedtime and instead of running for an hour on the treadmill. This is something that we are working on. I'm not sure that there is a very good treatment that can replace completely exercise, because it has a lot of effect. Exercise is improving sleep, improving mood, strengthening the well-being. So it's not working on one target, on one mechanism. And I think many other treatments will have different effect. Probably cognitive training has some benefit similar to exercise, at least in relation to Alzheimer's disease or cognitive functioning. And as I've said, in order to prevent or increase our cognitive and motor reserve, there are many ways. First, not to harm it. And as we've heard, sleep abnormalities or sleep apnea is affecting the cognitive reserve, either through vascular problems or through other diseases. So I think if you cannot do exercise, you can watch all other aspects that are playing a significant role in the risk to develop those degenerative processes.